Very good afternoon to all of you. So my topic for today is outcomes of vitrectomy with internal limiting membrane peeling in eyes with persistent chronic macular edema. We do not have any financial interests. The rationale behind the study was macular edema is a very common and significant risk factor for visual loss in diabetic retinopathy, vascular occlusions, and uveitis cases. Currently, antivascular endothelial growth factors, anti-VEGFs, drugs are considered as the first line of treatment for macular edema. However, due to short duration of action and need for multiple injections and monitoring visits are required, so these result into financial burden on the patients. Also, the previous report suggests that in spite of anti-VEGF injections for 6 consecutive months, up to 60% of the eyes still had persistent DME. PPV in cases with chronic macular edema reduces the traction by removing the posterior hyaloid, epiretinal membrane, and the internal limiting membrane. Pars plana vitrectomy with ILM peeling can be considered as an alternative treatment for chronic macular edemas. Aim of the study was to evaluate the results of pars plana vitrectomy with ILM peeling in eyes with persistent chronic macular edema. Methods: a retrospective case series where patients with persistent chronic macular edema who were treated with PPV with ILM peeling due to unresponsiveness to more than 4 intravitreal injections of either anti-VEGF or steroids were included. Subjects with a previous history of vitreoretinal surgery, grid laser for macular edema, and oral steroids were excluded from the study. Best corrected visual acuity and central macular thickness were noted pre and post PPV with ILM peeling. The results were 6 eyes of 6 patients were included in the study. Improvement in BCVA was noted in 5 out of 6 cases. Clinically significant reduction was noted in macular thickness in all of the cases. However, no statistical significance could be achieved because of the small case study size, and there was too much variation between the macular thickness pre and post-op. These are the pre and post-op images, OCT images with visual acuity of the patients. As you can see, all 6 had an improvement in the corneal thickness, central macular thickness, and visual acuity also improved in 5 out of the 6 patients. So the discussion comes, the possible mechanism includes ILM peeling reduces the epiretinal membrane formation further, which may be associated with a recurrence in macular edema. And it also removes the barrier between the retina and vitreous, thereby increasing the diffusion of large molecules from the retinal tissue into the vitreous cavity, thus resulting in a reduction in intraretinal osmotic pressure and elimination of water from the retina. ILM peeling also increases the oxygen diffusion from ciliary body to retina and improves the oxygen supply to retina. Pars plana vitrectomy may also remove some cytokines and inflammatory mediators within the vitreous, which causes leakage of the retinal vessels, and thus may also contribute to the reduction of macular edema. So concluding, pars plana vitrectomy with ILM peeling showed clinically significant reduction in macular edema in all of our cases. Reduction in macular edema post pars plana vitrectomy with ILM peeling could have a positive impact on the individual quality of life, reducing their cost, financial cost, and frequent visits to the clinics. These are the references.